Uh, Good evening, everyone. So I would be presenting the first line treatment for MET exon mutation non-small cell lung cancer. So MET mutation is reported to be mutually exclusive of other established molecular drivers like EGFR and ALK translocation. MET mutation in splice slide leading to exon 14 skipping result in MET14 juxtamembrane gain of function alteration, and it is originally discovered in small cell lung cancer and later in non-small cell lung cancer adenocarcinoma. It occurs in 3% of non-small cell lung cancer adenocarcinoma and 5 to 22% of other non-small cell lung carcinoma subsets like sarcomatoid variant. MET exon 14 mutations are linked to early stage diagnosis and older age. So this is the wild type MET signaling. So it is the ligand for the receptor is hepatocyte growth factor. As you can see, there is a transmembrane and juxtamembrane domain. In the juxtamembrane domain, there is a protein encoded by exon 14 region, and whenever this receptor dimerizes because of ligand binding, then there is phosphorylation and recruitment of signaling proteins, which leads to survival, decrease apoptosis, regulation of cytoskeletal function, growth differentiation, and stemness. So basically, it activates multiple signal transaction pathways like MAPK, PI3K, STAT, and NF kappa beta. So as Madam has already told that there is a MET exon 14 splicing mutation. So when in normal splicing, DNA leads to pre-RNA and pre-mRNA, then mRNA. So in that exon of sometimes there is an abnormal splicing which leads to exon 14 being skipped, and the resultant protein is being encoded only by exon 13 and exon 15. So this leads basically this exon 14 protein is required for binding of a protein called CBL, which leads to internalization of the receptor followed by degradation by ubiquitination. But because of the absence of this protein, there is no degradation, which leads to constitutive activation of this protein and decreased degradation, leading to continuous signaling. So it has been seen that MET exon 14 is associated with worse survival and was found to be an independent prognostic factor that predict worse survival compared to those without this mutation. You can see the overall survival and disease-specific survival both are less. It has also seen that MET exon 14 had poor response to immunotherapy drug also. The median PFS seen on those patients with MET exon mutation with PD-L1 positive was just 1.9 months. It has also been seen in retrospective series that MET inhibition prolongs survival in MET mutated stage 4 non-small cell lung cancer. Those who have not received had median OS of just 8.1 months, and those who have received has median OS of up to 24.6 months. So there are three types of MET TKIs: type 1, type 2, and type 3. The drug that is currently in use belongs to the type 1 category, ATP competitors that bind to ATP binding pocket of active form. Type 1A constitutes crizotinib, and type 1B constitutes the other drugs, capamatinib, tepotinib, and savolitinib. Then this is the current treatment paradigm for molecular biomarker positive advanced non-small cell cancer. Apart from the established driver mutations like EGFR, ALK, ROS, BRAF, NTRK, and RET, now MET exon 14 is also being recommended to be tested and to be targeted for treatment. So as Madam has already told that as per the recommendation right now, RNA-based NGS is the most sensitive test, although it has some flaws that Madam has already told that the RNA is not that stable. So there can be false reporting because of that. But it is right now the most sensitive and recommended test for MET exon 14 testing. Now, MET inhibitors that are being approved and in use are crizotinib, tepotinib, and capamatinib. So, crizotinib, all these tepotinib and capamatinib have been FDA approved for this indication. Now, capamatinib is a selective MET inhibitor, and it is the most potent among the other drugs, considering its the concentration needed for activity. Now, this drug was tested in phase 2 a multi-center open-label trial where there was 7 cohorts. Out of this, cohort 4, which constituted pre-treated patients with MET exon 14, regardless of MET gene copy number, and cohort 5B, which constitutes treatment-naive patient with MET exon 14. The primary objective of this study was to demonstrate the anti-tumor activity of capmatinib and overall response rate assessed by blind independent committee. The key secondary objective was duration of response. The other objectives were overall survival, anti-tumor efficacies, other efficacies like overall response rate, duration of response, time to tumor response, disease control rate were also there. When coming to the baseline characteristics of this study, so you can see the median age of the patients were 70 years, approximately 70 years. There was more of male patient with female patients constituting only 40% in cohort 4, and treatment naive patient only 18%. ECOG performance status of 0 and 1 were there. Brain metastasis was there in 15.9%. In cohort 4 and 10.7 in the treatment naive group. Concurrent MET amplification was also seen in this study, which I am going to talk later on. In cohort 4, as they were pre-treated, either patient where most of the patients were either post 1 line or second line of treatment, but few patients were also post 3 lines of treatment. The treatment line constituted of platinum-based chemotherapy mostly. Then these are the results for pre-treated cohort 4, where they have seen the partial response rate was around 40% in both investigator and blind review committee. The stable disease was 36.2 and 30.4%. The disease control rate achieved was up to 80%, and overall response rate was around 40%. The clinically there in cohort 5B patients, there was one CR by seen in treatment naive patient. The overall response rate here was 67.9%, and disease control rate was around more than 95%. You can see from the waterfall plot that many of the patient has achieved a significant decline responses from the drug. The median duration of response was 9.7 months in the cohort 4, that is pre-treated, and 12.6 months in the cohort 5B, that is treatment naive patients. The progression-free survival was 5.42 months in pre-treated, and those with treatment naive was 12.42 months. It has also seen that it has confirmed activity against brain metastasis. There is the 4 patient had complete resolution of all brain lesions, and around 7 out of 13 patient had an intracranial response, and all 7 responders in the brain had an intracranial response at first evaluation itself. Now there are other MET alteration also, and it has been seen that deep responses irrespective of the type of mutation were also seen with this drug, and co-occurrence of MET amplification has not too much of bearing on the results. Then the updated results, which included the expansion cohort 6 and 7, considering pre-treated in cohort 6 and treatment naive in cohort 7. It confirmed the result that overall response rate was around 67% for treatment naive patient, and disease control rate was more than 95% in treatment naive patient. In those who are pre-treated, the response rate, overall response rate were around 51.6%, and disease control rate was 90.3%. The majority of patients experienced a tumor response at first evaluation itself. The median duration of response to capmatinib was 12.6 months. It was 8.4 months in the second line and 9.7 months in the second or third line. The median PFS was 12.3 months in the first line, 6.9 in the second line, and 5.4 months in the third line setting. Then regarding the safety, as you can see, the main toxicity, the grade 3 and grade 4 toxicity was seen in 35% of the patient. The most common toxicity was peripheral edema, it was 41.6 in any grade, and 7.5% as grade 3/4 peripheral edema. Nausea and vomiting was also there, because initially it was given in fasting condition, and later on the food restrictions were removed. It was otherwise very well tolerated drug, and there was very limited grade 3 or grade 4 toxicity. So the peripheral edema, gastrointestinal symptoms, and increased blood creatinine was also seen, which was there was not any grade 3, grade 4 creatinine increase. It was just less than grade 2 creatinine increased. So preliminary efficacy result of expansion has confirmed the result that this drug has activity and shown to have good overall response rate and disease control rate. And the median overall survival was up to 20.8 months in the treatment naive patient, and 13.6 months in those who was pre-treated. The safety profile was okay, found to be okay. Now regarding the MET amplification, so there was one cohort where they have seen that those patients who have MET amplification, that is gene copy number more than 10 and no exon 14 mutation, in this cohort there was some improvement in response rate. The response rate was around 29% for the pre-treated cohort and 40% in the treatment naive patient. The duration of response was 8.31 months and 7.54 in treatment naive patient. So basically, in those patients who have high MET amplification, this drug can still act, but the major indication for this drug is for MET exon 14 mutation. The updated analysis has just confirmed the result of the activity of this drug with those who have MET amplification. The response rate around 27%. Those who have received it as a first line for MET amplification, it is 40%, and second line it was around 48.4%. Now there is the other drug, that is tepotinib. And this drug was also tested, and the primary endpoint of the study was overall response rate. The secondary endpoint was duration of response, progression-free survival, overall survival, and safety. It constituted patients with MET exon 14 alteration, either on liquid or tissue biopsy, and they have given the drug in first line, second line, or third line setting. So as you can see from this waterfall plot, over 90% of the treatment naive patient treated with tepotinib experienced the tumor shrinkage. The overall response rate was 54.7%. The median duration of response was 32.7%. The median progression free survival was 15.3%, and median overall survival was highest, that is 29.7 months. It has a manageable safety profile. The toxicity seen with this drug was almost similar to capmatinib, with peripheral edema being the major side effect apart from nausea and vomiting. The more than grade 3 toxicity was seen in 14.1% of the patient. Dose reduction has to be done in 15.6% of the patient, and temporary interruption was in 21.9%, and leading to permanent discontinuation in 6.3% of the patients. Then the conclusions from this study was there was fewer discontinuation, and the grade 3 toxicity was comparatively less, with peripheral edema being the major in more than grade 3 in majority of the patient, and only 4 to 5% of the patient had a permanent discontinuation of the drugs. But overall, this drug was very well tolerated. These are the key trials evaluating the MET inhibitors for MET exon 14 altered non-small cell lung cancer. First is crizotinib, which has shown overall response rate of 32%, median duration of response 9.1 months, and median progression-free survival of 7.3 months. Capmatinib, already I have told, overall response rate of 40.6 in pre-treated, 67.9 in treatment naive. Median duration, median progression-free survival 5.4 and 9.7 months respectively. Tepotinib has the best overall response rate, 50%, and median duration of response of 12.4 months. The median PFS was 9.5 months, which was comparable to capmatinib. The other drug that is there is savolitinib, and it has overall response rate of 47.5 months and median PFS of 6.8 months. So this is the NCCN guideline. It shows that those who have MET exon 14 skipping mutation should, if they have not started on any first line chemotherapy, they can go ahead with preferred one are capmatinib and tepotinib. The useful in certain circumstances is also crizotinib, or they can go ahead with systemic therapy also. Those who have already started, they can wait for their progression and later on to be started on capmatinib or tepotinib. These are the emerging biomarker, the high level MET amplification, and they have here they have defined it as gene copy number of more than 10. In few studies, more than 5 or 6 is also taken as cutoff, so it is still not very much defined. In those, there is, based on these preliminary results, these drug can act, crizotinib, capmatinib, and tepotinib. Although MET amplification is many times co-occurrence with other kinds of mutation, and it has been seen that those patients who have MET exon 14 mutation, they respond to capmatinib irrespective of the MET amplification status. These are the ongoing trials with many drugs in the pipeline of phase 2 and phase 3. So thank you.
Thank you, sir. For the next talk at this session is going to be on mechanisms of resistance to MET TKIs and treatment post-resistance in non-small cell lung cancer. I would like to invite Dr. Sudip Das, who is a consultant medical oncologist at Medica Super Speciality Hospital, Kolkata, to give the talk.